I'll begin by acknowledging the traditional custodians of the Ngunnawal Ngambri country where I am today. I'm a Takalak traditional owner from North Queensland, and I pay my respects to elders past, present and emerging, and thank them for their continuing efforts in protecting and nurturing our land and our culture. To everyone joining this award session today, wherever you are, let us take a moment together and acknowledge the rich heritage of where we live, work and gather. I'm deeply honoured to be given this award. Sidney Sax occupied a unique niche in the Australian healthcare system from 1973 to the late 80s. This was a period of transformational change at the Commonwealth Government level, and it would be of no surprise that Sidney Sax was a trusted advisor of the Whitlam, Fraser and Hawke governments. In his review of Sidney Sax's book, Healthcare Choices and the Public Purse, R.M. Douglas notes that the book begins with two assumptions: that society has responsibilities for those who are sick and disabled, and that modern civilization creates or contributes to many problems that are beyond our capacity to solve as individuals or through our families. He warns against another dismantling of universal health insurance. He believes that the experience between 1976 and 1983 is a warning to ever-committed libertarians, and that the strife of engendered and the associated system disruptions would be intolerable by both consumers and the majority of the healthcare providers. Sachs did not think we had much to learn from the Americans. He thought the chances of achieving efficiently integrated systems would be greatly improved by removing the division of responsibility between Commonwealth and state governments, and I, for one, couldn't agree more. He did warn not to hold one's breath while waiting for this to occur. It is interesting to note that it took decades for governments to progress many of the areas Sachs had identified for action. But for me, this was not new. There were many gains made in the 80s that were lost in the following decade. Buoyed by the Whitlam government's transformative legislative reforms, particularly the Racial Discrimination Act of 1975, and the development of the Northern Territory Land Rights Bill subsequently enacted by Fraser's Conservative government, our Aboriginal and Torres Strait Islander people were optimistic of furthering the pursuit of recognition and self-determination into the 80s. The outcomes our Aboriginal and Torres Strait Islander people were seeking were aligned: recognition through national land rights, a treaty and formal structures that would ensure Aboriginal and Torres Strait Islander people had direct access to government, and the leadership in the development and implementation of policies and programs. However, the widely held descriptions of the 80s being the decade of boom and bust also held true for Indigenous affairs. The capriciousness of Australian politics continued the dispossession of Aboriginal and Torres Strait Islander peoples. The state of mind of our Aboriginal and Torres Strait Islander peoples went from one of elation to feelings of utter betrayal by the Labor government. Hawke's commitment to negotiate a treaty was reduced to a process of reconciliation, and national land rights legislation was abandoned. This was followed by the Howard government's decision to dismantle ATSIC. While Sachs was pursuing the reduction of socio-economic inequalities and increased emphasis on the management of chronic disease, Aboriginal and Torres Strait Islanders were establishing NACCHO, which is now known as NACCHO, and our first Aboriginal Community Controlled Health Service, the Redfern Aboriginal Medical Service, which is celebrating its 50th anniversary this year. Both the need and the strong desire by Aboriginal and Torres Strait Islander peoples to pursue culturally safe healthcare for our communities has resulted in there now being 143 Aboriginal and Torres Strait Islander community-controlled health services across Australia, delivering around 3 million episodes of care per year through 550 clinics and outreach services. Our sector is the third largest employer of Aboriginal and Torres Strait Islander peoples. In my view, it is this longevity, connectedness and resilience that has enabled the strong and proactive response to the COVID pandemic. Australia's COVID story is one you might all know. However, you may not know the full story of the community control sector's response. Our sector mobilised quickly because we had to. Already in January 2020, Apunapina in northern Queensland was preparing a response to protect Aboriginal and Torres Strait Islander people in that region. In early March at NACCHO, we convened a meeting in Canberra which included CEOs and Aboriginal doctors from several of our community health services, affiliate CEOs and public health medical officers to get our heads around this new virus. The Commonwealth joined this meeting and subsequently established the Aboriginal and Torres Strait Islander Advisory Group on COVID and included state and territory government officials. As Deputy CEO of NACCHO, I continue to co-chair this advisory group with Dr. Lucas Dutoka from the Commonwealth Department of Health. It links to the Communicable Diseases Network of Australia and reports to the Australian Health Protection Principal Committee. From that day to this, the sector was out on the ground informing communities about the facts. We advocated early with the Territory Land Councils for border closures and protective biosecurity measures to keep our communities safe, supporting communities with local pandemic planning, using social media, radio and local leaders to spread the word, developing appropriate rules for funerals and sorry business, working on how to get medications to people in quarantine, and we introduced daily health monitoring systems for anyone at high risk. While the sector was busy responding on the ground, we were also at the front and centre in national pandemic policy making. Our sector ensured legislative changes, including the Biosecurity Act, to enable the necessary restrictions to be put in place quickly. National and Aboriginal and Torres Strait Islander public health guidelines, including the evacuation criteria, standards for isolation and quarantine, social support, clinical care and community-wide COVID screening, immediate telehealth uptake that kept people well, rapid PCR testing in over 80 remote communities, workforce surge capacity, planning and infectious disease modelling. This was just an amazing effort by all, and it worked. Throughout 2020, the sector's mobilisation meant a much lower rate of COVID infections among Aboriginal and Torres Strait Islander peoples. Last year, there was not one death from COVID among Aboriginal and Torres Strait Islander people. In 2021, however, a new variant of COVID and the deeply embedded social determinants of health have taken their toll. This year, there have been 4 Aboriginal people that we are aware of who've died because of COVID. Notwithstanding this battle against the COVID pandemic is now in its 18th month, our sector continues to deal with the challenges thrown at us. The most significant enabler in our response nationally has been the recognition by the Commonwealth Government of the Aboriginal community-controlled health sector as a key plank in the health architecture of Australia, delivering primary health care and in particular for the response to COVID. 20 ACCHOs were commissioned as general practice respiratory clinics. The government is allocating vaccines direct to our Aboriginal health services, and at the last count, 177 clinics in the sector were delivering the vaccine across the country and had ordered over 300,000 doses of the vaccine since the start of the rollout. As of 13 September 2021, a total of 233,800 or 39.55% of Aboriginal and Torres Strait Islander people have received at least one dose of the COVID vaccine. As of 13 September 2021, 131,092 or 22.18% of Aboriginal and Torres Strait Islander people are fully vaccinated, and in excess of 29 million has been provided to NACCHO to fund ACCHOs and other Indigenous organisations to assist them with the response and the vaccine rollout. What is important, however, is it was granted in a way that allowed flexibility, thereby enabling programs to be designed to meet the needs of the community at the local level. This partnership with the Commonwealth Government must continue if Australia is to reduce the burden of disease for Aboriginal and Torres Strait Islanders, which is 2.3 times that of other Australians and in remote areas 6 times. We can't rely on the whim of whoever is in government and individuals. And to this end, NACCHO and other members of the coalition of peak organisations will assiduously pursue the implementation of the National Agreement on Closing the Gap. And how can we not, given the challenges we still face? Cancer is now the leading cause of death for Aboriginal and Torres Strait Islander people. We have a high rate of cancer diagnosis and approximately 40% more likely to die from cancer than non-Indigenous Australians. The highest cancer incidence rates for Aboriginal and Torres Strait Islander people are lung cancer, breast cancer, colorectal cancer and prostate cancers. Other significant challenges for our sector in meeting the health needs of Aboriginal and Torres Strait Islander peoples include mental health and suicide, road safety fatalities, and non-communicable diseases like heart disease. Mental health and suicide affects us every day. 11% of presentations at emergency departments across the country are Aboriginal and Torres Strait Islander people, yet we are only 3% of the population. And in 2010, suicide was 2.6 times more likely to be the cause of death than for non-Indigenous Australians. It is significantly higher for our males under 25 years of age. The number of Aboriginal and Torres Strait Islander people involved in road accidents and fatalities is disproportionately high. We are 2 times more likely to die and 1.4 times more likely to suffer serious injury because of motor vehicle crash compared to other Australians. Our sector's model of primary healthcare integrates health promotion, community development, social action with clinical services and individual healthcare. We are delivering primary healthcare that others can only dream of. Continuity of care in community-controlled health services decreases the rates of hospitalisations. Our communities direct us and our communities trust us. One of the major studies concluded that 50% more health gain could be achieved if health programs were delivered by Aboriginal populations via Aboriginal community control compared to the return on investment if the same programs were delivered via mainstream primary care services. Very recently, a planned transition of a remote primary healthcare service from government management to community controlled increased utilisation of primary healthcare by 408%. This transition accelerated immunisation rates. It reduced the proportion of low birth weight babies to less than 10% of the entire birth cohort. It increased employment of qualified Aboriginal and Torres Strait Islander people. To wrap up, I will finish with a few words that I've heard about Dr. Sidney Sax. It was said that behind his unassuming manner lay a fierce radical. With foresight, he identified the need for strategic action on health equity, social determinants of health, regional health planning, and the importance of navigating strife of interest in healthcare. He recognised that considerable effort is required to bring everyone together to row in the same direction for the public's health. In accepting the Sidney Sax Medal, I would like to recognise the amazing work of the Aboriginal and Torres Strait Islander peoples, past and present, who are part of our community-controlled health sector. Our services were established out of a need for our people to have not only access to healthcare, but care that is culturally safe. Our sector is fiercely radical too. Our model is an act of self-determination. One of the participants at a recent consultation session on the development of the core services framework, which articulates our model of comprehensive primary healthcare, stated, "To call yourself a more comprehensive primary healthcare service, you need more than a sick care service. You also need to be public health advocates to garner action on poverty and overcrowding. You must invest in communities, develop leaders, and reclaim community empowerment. You must look to act on social determinants of health as well." Thank you.